Hello, my colleagues. This is the second episode of Universal Expert Studio. This is the second episode regarding the heart failure. We have the first episode in heart failure patients presented by Dr. Hassanin and Dr. Sanhuri and myself, and then we discussed the clinical part and the diagnosis, and then we reached to how to optimize treatments. I have with me Professor Hassanin, Professor of Cardiology, Alexandria University, and the past president of the Working Group of Heart Failure, and past president of the editor-in-chief of Egyptian Heart Journal. And also Dr. Muhammad Sanhuri. Dr. Muhammad Sanhuri is Professor of Cardiology in Alexandria University and one of the pioneers of electrophysiology in our department and in Egypt. My name is Muhammad Sobhi, Professor of Cardiology at Alexandria University. I'm chairman of the CVREP Foundation, past president of Egyptian Society of Cardiology, and the steering committee of East chapters in Middle East and Africa. Dr. Hassanin, Dr. Sanhuri, you remember the patients. You have to revive the patient again, how to make a decision and how to optimize. We stopped at this slide, and then you can go for your case.
Well, I'm pleased to be with you in this second series of heart failure with reduced ejection fraction. I'm also happy to be with Professor Muhammad Sobhi, Dr. Muhammad Sanhuri. I would like to remind you of our patient. He's a 58-year-old gentleman who presented with dyspnea, New York Heart Association class 2, orthopnea, diminished exercise tolerance, and swelling of his ankles. His physical examination revealed an elevated jugular venous pressure, third sound gallop over the heart, and bilateral lower limb edema. The abdomen looked normal except for mild hepatomegaly. Well, this is his current medication. He's on enalapril 10 milligram twice daily, carvedilol 6.25 milligram twice daily, aspirin, spironolactone 25 milligram once daily, furosemide 40 milligram every other day, atorvastatin 40 milligram, Actos, which is bioglitazone 30 milligram with glibenclamide 5 milligrams, and metformin 800 milligrams, and naproxen, OTC. I would like to remind you that most of the patients would not mention their non-steroidal anti-inflammatory drugs because they are OTC on the shelf or on the counter, and they think it's not important to tell the physician about their other medications. Well, Professor Sobhi.
This is the guidelines. Dr. Sanhuri, I like the guidelines. This is the way of treatment. The green color is a class 1, the yellow is the class 2A. So let's go for the green. The green on the bar here, diuretics we given to as long as we have signs of congestion. And then we start with the ACE inhibitors and beta blockers both. When do you change to ARBs?
If your patient is not tolerating ACE inhibitors, we can shift to ARB. If the patient has a combination of ACE inhibitor and a beta blocker and is still symptomatic, we should go to the next step to add mineralocorticoid receptor antagonist, proved to reduce the mortality and the heart failure hospitalization. So the place of ARB here if the patient is not tolerating ACE inhibitor.
This is an important point, Dr. Samir. I would like to add that I see that many physicians will go directly to ARBs and forget about ACE inhibitors. I think this is not in accordance with the guidelines. All patients should try first ACE inhibitors. And so if they are intolerant to the ACE inhibitor in the form of cough, very irritant cough or angioedema, then we may resort to R's, but not the reverse.
Yes, the cuff is about 10 to 15%. Sometimes there is a cuff due to congestion, so he thought that the cuff is due to the ACE inhibitors. We have to exclude the other causes of cuff rather than the ACE inhibitor. Regarding the beta blocker, this is the first choice. Also, most of the doctors are afraid to take beta blockers at the beginning because of the congestion. No, you can take a small dose, and then we're going to speak about the beta blocker. The ejection fraction 35 here, in the yellow, in the white part. If the ejection fraction is still yellow, add mineralocorticoid. This is a green, this is class 1. So ACE, beta blocker, mineralocorticoid is. Then if there's still symptomatic ejection fraction less than 35, we have 3 options. Either to change to ARNI, which is the green here. If the sinus rhythm QRS duration more than 30, ivabradine, we're waiting for the heart rate, if more than 70. So the heart rate crucial point is the 70, according to the SHIFT trial. 70 is important. We have to remember the ejection fraction 35 and the heart rate 70 and the QRS duration 1/3. Dr. Sanahouri, do you think that the QRS duration is important in your evaluation in general?
Yes, QRS duration is very important, and this is the most proved indication or the most proved predictor of benefit from implantable device like a CRT. The more the QRS width, the more your patient will be one of the responders to the CRT. So our patient has, as you remember from the ECG, has a QRS width more than 150, which is a class 1A indication to implant a CRT in order to improve his heart failure state and mortality.
Beta blockers. I'm from the generation with Dr. Hassan who started the beta blocker in heart failure, and carbidopa is one important. The carbidopa is 6.25, and we have 25, and we have 12. So 6.25, this is a small dose of the carvedilol. We have a question here. This patient is resting heart is 90. So what is the optimal heart rate for the patient with half ref? Either with the patient is taking 6.25 twice daily, you keep the same dose, or they increase the current dose to 12.5, or remove carvedilol to change to other beta blocker.
No, in this patient, I increase the dose because the guidelines recommend for carvedilol dose up to 25 milligram twice daily, as long as the patient is tolerating this beta blockers. If the patient is not tolerating the high dose of beta blocker, I'll add the second line, which is the ivabradine, according to the SHIFT trial.
Dr. Hassaneen, do you believe in the phenomenon that you start small, increase slowly, up titrated, or you start with the bigger dose according to the guidelines of the beta blockers?
Once the patient is decongested, and this will be, I think, the next day the patient is admitted to the hospital, I start a small dose of carvedilol. Even the sickest patient, I can start on 3.125 milligram twice daily, which is half a tablet of the 6.1.
Yes, you can see here the guidelines.
Start, yes, with the smallest dose and increase gradually according to the patient tolerance. Every 1 or every 2 weeks, I would double the dose. So if I start with 6.25, I'll double the dose after 2 weeks to 12.5, and further after 2 weeks, I'll reach the target dose of 25 milligrams twice daily according to the guidelines.
Neprilysin starts small dose, reaching 1.25 to 10. Usually this is according to the senior trial, so this is mainly the elderly, I think. Bisoprolol with the Cypress trial, starting those small dose, reaching up to 10. I think the bigger dose usually in the trial, but we start the small dose, up titrated till reaching the maximum. Then carvedilol, as you said. The third one is a metoprolol, which is XL, not XL. Now, so we have 4 types of beta blockers. You can choose each one of them, but neprilysin usually in the elderly, but others can be used, bisoprolol, carvedilol. But most important carvedilol because they have a lot of trials for heart failure patients.
Yeah.
Let's go for the guidelines, Dr. Sanahouri. This is stable. Class 1A means that you should do it.
As we mentioned at the first place, we start with the ACE inhibitor. And then we add the beta blockers. If the patient is symptomatic despite the use of ACE and beta blockers, we'll go to the next step, which is a mineralocorticoid receptor antagonist.
You said ivabradine in your talk. This is the SHIFT trial. This class 2AB Let's stop here on the ivabradine. Ivabradine depending on the heart rate.
Yes.
The shift trial in the heart rate.
If the beta blocker, for example, the patient has bronchial asthma or other contraindications for beta blocker, his blood pressure is low, I can add ivabradine because ivabradine, it does not affect the hemodynamics of the patient. Even the patient's blood pressure is low, I can add ivabradine. If the patient cannot tolerate higher doses of beta blocker and still his heart rate, for example, is 80 or 85, I can add ivabradine, either 5 milligram twice daily and then up titrate to 7.5 milligram twice daily.
You should reach to the maximum tolerated dose of ACE inhibitor. And for enalapril, the maximum dose is 20 milligram twice daily. But as Paradigm Heart Failure trial told us, when it compares in more than 8,000 patients, compared enalapril 10 milligram twice daily versus sacubitril valsartan. And it proves a mortality benefit for sacubitril valsartan over the enalapril. So in this patient who is still symptomatic despite the dose of enalapril 10 milligram per day, it's a good option to shift him to ARNI in order to improve the symptoms and reduce mortality.
Entresto or ARNI should be used if there is no hypotension. Very important is not potassium in high potassium. We start if the patient was in ACE inhibitor, you have to stop 36 hours. And then you give the Entresto. Otherwise, the patient will go to hypotension. If the patient ARBs, you can go to Entresto. But if they're taking maximum ARBs, take 100 twice daily. If there is not maximum ARBs, our ACE inhibitor you should 50 twice daily and then increasing. الدكتور حسنين Entresto أو sacubitril valsartan, when do you increase the dose? يعني every week, every 2 weeks, depending on ejection fraction. How can you assess? The ejection fraction is important. Can you use it in acute heart failure? Dr. Hassanin, we have Dr. Senouri said there is a paradigm heart failure, which is very important. We have changed the guideline. I think this 20% reduction. It's good for for this Entresto, our sacubitril valsartan. It should be used if there is no hypotension. Number 2, if the patient is not having hyperkalemia. The third, that you can, if they have an ACE inhibitor, you should stop the ACE inhibitor 36 hours.
It's very important.
If you have an ARBs, you can, or ACE inhibitor, a minimal dose, not target dose, you can use 50 milligram twice daily. If it is maximum dose, 100 milligram twice daily. My question to you, different questions. Question number 1, when do you up titrate? How do you up titrate? Number 2, for the dose. Number 2, can you give it in a hospitalized patients recovered from heart failure? Number 3, the ejection fraction.
Well, let's start one by one. Patients hospitalized with acutely compensated heart failure, I have to control the acute heart failure status first, and the patient should be stabilized. He should not be on intravenous diuretics. He should not be on intravenous vasoactive drugs like inotropes. So if the patient fulfills this condition, I can start ARNI or Entresto in the hospital before discharge. The dose depends on the blood pressure. If the patient, first the blood pressure, systolic blood pressure should be at least above 100 millimeters mercury to start 50 milligram of Entresto twice daily. Okay?
I think can add to this, if the patient cannot tolerate the hypotension, if the patient not congested, decrease the dose of diuretics, very important. And you can increase this because the diuretics indeed does not prevent the mortality or decrease the mortality, it depends on the congestion. This is a very, very important part of the Entresto drug. Second, regarding the left ventricular remodeling, yes, ejection fraction, sometimes the patient improves quality of life, it prevents sudden death. Don't depend on ejection fraction for the control, because sometimes the ejection fraction is stable, but the patient is improved. So this is not important on Dr. Sanahoori, let's go for another part. Let's now finish the ACE/ARBs, beta blockers. Now spironolactone. Our patient has serum potassium 5.6. You maintain the same dose, increase the current dose to 50 grams twice daily, or half the current dose, or remove the spironolactone and change it, maybe number E to change to Neprilysin, for example.
Like spironolactone has a mortality benefit. At the same time, the patient has mild hyperkalemia. The potassium is 5.6. And as we mentioned at the beginning, the patient has potassium supplement salt. So we can stop this supplement salt, reduce the potassium in diet, and keep the same dose of spironolactone. Shift to ابريرينون is a good option according to the Emphasis Heart Failure trial because it has a mortality benefit. So generally, I'll keep mineralocorticoid receptor antagonist dose, giving the mild hypokalemia, and I'll keep close follow-up of potassium level.
I stress on the dose of the RALS trial, not 100 milligram. It's 50 up to maybe second 75, but 50 is important. Number two, EFSAS trial, EFSAS 1 and EFSAS 2 in heart failure is important. This is an option, particularly in patient with hyperkalemia and patient of maybe gynecomastia for spironolactone. Dr. Hassanin, can you add anything to this, or you add?
Yes, I agree with Dr. Sanahoori that mineraloreceptor antagonists form an integral part of the treatment of heart failure with reduced ejection fraction. It's class 1, recommendation class 1, and level of evidence A. So I should look for other causes of hyperkalemia in this patient. As mentioned before, the patient on potassium salt. And remember that the patient is on non-steroidal anti-inflammatory drug. And those drugs raise the serum potassium. So if I stop the non-steroidal anti-inflammatory drug and the salt, potassium salt in his diet, I think the serum potassium will go down. Another point is important when you find elevated serum potassium, perhaps the technician who will draw the blood had made a mistake.
Dr. Sanahoori, this is the detrimental effects. Can you illustrate this?
Yes, non-steroidal anti-inflammatory medications inhibit the prostaglandin senses on the production in the kidney, like prostaglandin I2, and it decreases the excretion of free water and it decreases the excretion of sodium and potassium. So it could induce hyperkalemia, maybe increased fluid retention. It attenuates the effect of antihypertensive medications. The patient may take antihypertensive medications and not controlled simply due to the non-steroidal anti-inflammatory drugs, and it is one of the causes of exacerbation of previously compensated heart failure.
So the hyperkalemia in our patient is mild, and this level should be reversed easily if the patient advised, Dr. Hassanin asked that to stop the potassium salt substitutes and decrease the intake oral intake potassium-rich foods. We stop non-steroidals. Question: are non-steroidal appropriate for the patient? Do you increase the risk of hyperkalemia? Yes, it's a caution. And this is in the guideline, proves grade 3B, non-steroidal or COX-2 inhibitor is not recommended in patients with heart failure as they increase the risk of heart failure, worsening of heart failure, without putting in the factors triggering acute heart failure. One of them is non-steroidal.
I would like to add that it's also COX-2 inhibitors, not just non-steroidal anti-inflammatory drugs.
Dr. Hassanin, في novel drugs for treatment of hyperkalemia.
Yes, there are novel drugs because as I said before, most of the treatments used for treatment of heart failure, like RAS inhibitors, beta blockers, MRAs, they increase the serum potassium. And these are life-saving medication. Patients should keep on them. But the limitation that sometimes the serum potassium goes up, and this may lead me to stop one of these very useful medications. There are novel drugs for treatment of hyperkalemia. It is potassium binders, the petiromir, a novel drug, and zirconium cyclosilicate. Okay. I think these medications will be soon available in the Egyptian market.
Let's come back to the original slides. Patient symptomatic heart failure, reduced ejection fraction. This patient shifted now from this ACE, we have an ACE inhibitor, a beta blocker, but still symptomatic. Yes, we added mineralocorticoids, we still the dose because it's 5.6 potassium. But this patient, Dr. Sanhuri, is still symptomatic. We have three options here. Sinus rhythm, his heart rate more than 7. You give them this patient ivabradine, already is taking ivabradine. We have two options, able to tolerate ACE or ARBs, well, not, أو sinus rhythm. فأنا to change to ARNI or not to change to ARNI. Let's go for before this, diuretics. Diuretic of this patient, just asking to Dr. Hassanin and Dr. Sanhuri about the dose of loop diuretics. Are they continuing for a long time, bigger doses? Questions, increased frequency for symptoms, ولا increased dose, ولا substitute torsamide, هل في resistance في Lasix resistance or loop diuretics, ولا institute to IV torsamide in the hospitals?
Well, I think that the dose of diuretic here is inadequate. 40 milligrams even every other day or every once per day is not adequate to control the congestion. So I may increase the dose of furosemide to 40 milligrams twice daily. Or I may substitute furosemide for torsemide, or even I may go to higher dose of furosemide. For example, the 500 milligram tablet, I may give the patient a quarter of the tablet twice daily. Or in resistant cases, I may resort to intravenous.
If the patient takes the appropriate dose or the maximum tolerated dose of diuresis, and still he has a volume overload symptoms of pulmonary congestion. So in this case,
change torsamide, okay.
For diuretic resistance, we can manage if we combine diuretics working by different mechanisms. We can combine loop diuretics with thiazide and thiazide-like diuretics.
أنا في important questions other medication. احنا we had ACE, we had the ACE, وعندنا diuretics. We speak about diuretics or beta blockers with ivabradine. هل other drugs هنا digoxin؟ هل digoxin هذا rule؟ Still هذا rule؟
Yes, and in the last guidelines of heart failure 2020, digoxin is class 2B. If the patient is in sinus rhythm and have resistant heart failure symptoms, despite all the pharmacological and non-pharmacological measures, digoxin still have a place.
Dr. Hassanin, nitrates والهيدرالازين.
I want to add
digoxin?
Yes, to digoxin. If you have to give digoxin, and I think it would be useful in patients with heart failure, uncontrolled atrial fibrillation. But please, you should always monitor the serum level of digoxin, because the patient usually has impaired kidney function and may easily relapse into digitalis toxicity. So if you have to give digoxin, although the evidence in the guidelines is weak for digoxin, you should monitor the serum digoxin level always. For nitrates, unless the patient has angina, I would not add nitrates to even if the patient is ischemic and he had CABG, but now he has no angina. Perhaps it's cardiomyocardium. So nitrates would lower the blood pressure, and unless the patient is symptomatic with chest pain, I would never prescribe nitrates.
There's some publications about the use of this in some form of heart failure. I'm use it in heart failure in non-ischemic cardiomyopathy. It's not in ischemic cardiomyopathy. Astonishing. Maybe in the metabolic theory in heart failure it could be, but it's not class 1 in heart failure. It could be an added. Class ivabradine, maybe small of digoxin, trimethylene class 2B. And guidelines, this is the guideline. Digoxin may be considered in symptomatic patient. In sinus rhythm, despite treatment in ACRBs or beta blocker, mineralocorticoid to reduce risk of hospitalization. Both all cause 2BB. الهيدرازين والأيزوسوربيد ده 2AB. يعني being class 3, 4 in some cases. The ARBs in the patient is shifted. PUFA preparation considered in symptomatic heart failure patient use the risk of cardiovascular hospitalization. This is astonishing to be in 2BB. Let's go for ARNI. احنا speak paradigm with other drugs. Yes, this is still a rule for ARMI. Achievement target dose of beta blocker. Add ivabradine. Let's go for treatment. This patient is diabetic. Listen, come to this important. Diabetic patients. Patient taking the pioglitazone. Hal to maintain the same dose, Dr. Hassanin, have current dose, increase the dose, or remove substitutes?
Well, I would like to add data from our Egyptian research of heart failure that diabetes is very frequent in patients with heart failure. About 42% of males with heart failure have diabetes, and the prevalence rises to 48% of women with heart failure have diabetes. So it's very high prevalence in comparison to European and American Jews. So the combination of heart failure and diabetes is very common, and you have to take care of the anti-hyperglycemic drugs the patient is taking. For example, pioglitazone. Pioglitazone is known that it may precipitate heart failure. It increases the peripheral edema. So, according to the guidelines, pioglitazone should be abandoned. It worsens heart failure and it should be stopped.
Okay, so we stopped.
Yes,
دكتور سنهوري انا كله لك كلاس 3 بي كل البيشنتس دول yes.
One group are absolutely contraindicated heart failure patient, as Professor Hassanin mentioned. Also, non-steroid and anti-inflammatory drugs, even COX-2 inhibitors, are absolutely contraindicated. The negative inotropic effect of calcium channel blockers, verapamil and diltiazem, make it contraindicated in heart failure. And the addition of ERB to ACE inhibitors or to renin inhibitors, except if in rare cases when the patient cannot tolerate mineralocorticoid receptor antagonist, the guidelines mention that you can combine even ACE inhibitor with ERB in this particular patient who cannot tolerate mineralocorticoid receptor antagonist. But this is not the rule.
But no, I'm sorry. No. This is nephrology. It was in the past a nephrology concept, but nowadays it's contraindicated to add ACE to RBs. Contraindicated non-steroidal COX, contraindicated verapamil and diltiazem, contraindicated glitazone. This is class 3, and I like class 1A and class 3. In between a questionable. هنا بقى الكومباينيشن ثيرابي الحسنين الميتفورمين هل keep the combination the same ولا administer the same dose twice daily ولا remove the substitutes?
Metformin is not contraindicated, it's used with heart failure, but we have more beneficial drugs for treatment of diabetic patients which will improve his hemoglobin A1C and at the same time will improve cardiovascular outcomes, and these are the sodium glucose co-transporter inhibitors.
Yes.
They are very useful new drugs. We have the cardiovascular outcome trials, we know the EMPA-REG Canvas program and DECLARE TB58, which prove that using these agents in patients with heart failure will reduce heart failure hospitalization by almost 30%. And we have also two important trials, the DAPA-HF, which dapagliflozin was used in patients with heart failure. It reduced the combined primary endpoint of cardiovascular death and hospitalization for heart failure. And we have very recently, since just 2 months ago, the EMPA reduced heart failure using empagliflozin in patients who were more severely ill with heart failure than those in the DAPA-HF. And again, the combined primary endpoint of cardiovascular death and heart failure were reduced by 25%. So we have now firm evidence that sodium glucose transport 2 inhibitors they will reduce hospitalization of heart failure and they will reduce cardiovascular death.
Hassanin, now patient is taking a diuretics loop, mineralocorticoids, beta blockers maximum dose, taking ivabradine, and is taking Arni, a small dose of digitalis, taking SGL2 now. I think he's taking DAPA or Forsega, 10 milligram. فاحنا 7. Dr. Sanhuri, still our patient is symptomatic. فده the ECG hint to further possible treatments. يعني انت looking for ECG هل مثلا ICD, CRT, left ventricular assist device او cardiac contractility modulation. What do you think?
Yes, according to the patient condition, he received the maximal now tolerated doses of anti-failure medications and he is still symptomatic. So according to guidelines, I can offer him a non-pharmacological device-based therapy. For this patient with typical left bundle and wide broadened QRS complex, I'll prefer him for implantation of a CRT, cardiac resynchronization therapy.
Why? Because he's still symptomatic, yes. Ejection fraction less than 35. QRS morphology, yes. QRS width is 150. An optimum medical therapy, no.
Now we reach it to the optimum.
واحنا هنا class 1A اللي هو CRT is recommended for symptomatic patient. Heart failure, sinus rhythm, QRS more than 150 despite OMT, like optimum medical treatment or guided medical therapy to improve symptoms. With CRT should be considered for symptomatic patient heart failure in sinus rhythm. QRS بقى 150. هنا الدسكشن على ال 150 130 ده. يعني انا عايزك تلستريت اكتر دلوقتي. It should be 150 ولا مثلا in between.
Yes. So according to the heart failure guidelines, CRT is indicated if the QRS complex is more than 130. But the best responders and the strongest evidence was for QRS complex more than 150. This is the best group who will respond to CRT, who have a QRS complex more than 150. But more than 130, you can offer the patient a CRT, especially if he has a left bundle branch block morphology. If the patient has a QRS complex more than 150 and the non-left bundle branch block morphology, he still may benefit from the CRT, but the class of recommendation is 2A. If the patient has a QRS complex between 130 and 150 and the non-left bundle branch block morphology, it is not preferred to offer him a CRT. It's a class 2B.
A patient ده liable to sudden death. الأرني one of the drugs which يعني decrease sudden death to improve quality of life. The CRT improve heart failure. And you need AICD in all patients, CRT ICD ولا only CRT?
So in this patient, it is debatable to implant a CRT or CRT-D. But according to their statement mentioned in the guidelines, if your main aim to treat is to improve the symptoms, you will implant a CRT-B. If the main aim is to reduce the sudden cardiac death, you will implant a CRT-D. So CRT-D here is a good option because this patient have ejection fraction according to what mentioned in the guidelines less than 35%, and he was on optimal medical treatment for more than 3 months. So to offer him a defibrillator in addition to CRT, this is a good option in order to reduce the sudden cardiac death.
Dr. Hassanin, I don't think.
If this patient is on optimal medical treatment and he is now asymptomatic, would you still recommend CRT for this patient if he is compliant on treatment and he is now asymptomatic?
No, if the patient is asymptomatic on optimal medical treatment according to the guidelines, I will not offer him a CRT.
طب reverse بقى لو عنده severe symptoms مثلا grade 3 to 4.
Yes.
Pulmonary edema.
If the patient has terminal heart failure, inotrope dependent, always hospitalized with heart failure, what we call always in NIHA 4, not ambulatory NIHA 4, ambulatory NIHA 4, which requires intermittent inotropic support. This patient has generally a poor life expectancy, less than 1 year. So he is not indicated for any device-based therapy, whether CRT or ICT. But in this patient, we may implant left ventricular assisted device as a bridge to recovery or a bridge to heart transplantation even.
يعني انا if there is resistant symptoms despite ان الارني والايفابرادين والسي ار تي دي عندك resistant symptoms عندك no further action لكن yes عندك في option لسه still left ventricular assist device or heart transplantation. Let's summarize what we said in this episode. In a patient with symptomatic heart failure with reduced ejection fraction, class 1A therapy with ACE inhibitors and beta blockers when the patient tolerated the ACE inhibitors. If still patient still symptomatic, yes add mineralocorticoids. في symptoms mineralocorticoids يبقى ممكن عندك في السبيرولولاكتون او المينرالوكورتيكويدز اللي هم ابريلينون. والماكسيمم توليريتد دوزز معروفه ان هي 50 و 70 ملغ. ستيل سيمتوماتيك ايجكشن فراكشن يعني مينز يعني عندك سيمتومز وايجكشن فراكشن. في ساينس ريزم ديوريشن يبقى سي ار تي. ساينس ريزم مور ذان 70 يبقى برادين. بوث يبقى برادين والسي ار تي. بس you have to change it. A question and you can start ARNI from the beginning. Still it's a position statement. It's not in the guideline class 1A. But I think in the future the ARNI will be class from the beginning. Will not start with the ACRBs because most of the trials come. Maybe next guideline will change to be ARNI at the beginning with the beta blockers. Then finally, if there is symptoms, we have to go to the guideline. But we can add this, Dr. Hassanin.
Yes, this is an update of the guidelines of the European Society of Cardiology, where it says that if the patient is type 2 diabetes and is at high risk of cardiovascular disease, and if he's naive for his treatment for diabetes, he should be put on sodium glucose co-transporter 2 inhibitors or GLP-1 receptor agonists, even before metformin. If he is already on metformin, then I can add one of these two classes. This is the new trend in the guidelines.
Okay, this is the final slide.
Yes, yes. I would like to, this is the future treatment of heart failure. It's 4 pillars. The foundation therapy of heart failure, I think this will be in the next guidelines. Every patient with heart failure with reduced ejection fraction should be on an RD, which is Entresto, beta blocker, mineral receptor antagonist, and sodium glucose transporter inhibitors, even if the patient is non-diabetic. This was shown in the recent trials, cardiovascular outcome trials, the NAP-HF and the EMPRO reduced. Half of the patients had no diabetes, and they did benefit from sodium glucose co-transporter inhibitors. So these are the 4 pillars for treatment of heart failure with reduced ejection.
I think the patient now is lucky to have 2 experts with me in treating these patients. But my advice is to the better diagnosis of the patients, or number 1, diagnosis of heart failure, and then you should do the most important lab and the ECG, X-ray, and echo in all patients, and search for diagnosis if reversible cause of heart failure, and search for causes of refractory heart failure. Sometimes Sنهورى refractory heart failure, يعني patient heart failure بس في recurrent hospitalization. What do you think? When do you ask why the patient is admitted again to the hospital?
Yes, and I should ask myself, and I should search for any correctable cause. The most important is non-compliance of the patient.
Yes.
If I ask the patient about medications, he may take the medications on non-regular basis every other day. And the second is drugs that exacerbate the heart failure, like non-steroidal anti-inflammatory, and most important, steroid medications. This is very important point to ask the patient. And the doses of the drugs, whether the patient is on optimal doses of medications or not. The regular lab analysis to exclude anemia. Anemia could complicate the course of heart failure, or electrolyte disturbances, or even kidney dysfunction of the follow-up.
Usually the infection, ischemia, arrhythmia, pulmonary embolism, pregnancy, volume overload, not taking drugs. These come on the I think with this, I remember when I was resident, to look for the other causes. But we are lucky that we have nowadays the 4 pillars: ARNI, beta blocker, mineralocorticoid, and the SGLT2 inhibitor. I think we have come to the end. Thank you very much, Professor Hassanin and Professor Sنهورى. And I hope that we can illustrate in 2 episodes how to diagnose heart failure, how to reach that optimized treatment with all pillars we have. And I hope we can see you in another episode. Thank you very much.